Hi, I'm David Levine. I'm co-chair of Science Writers in New York. My other co-chair, Joseph Bonner, who you can't see, is behind the scenes, and he's making this happen. And he will also put it on YouTube for people who could not make it tonight. My guest is Dr. Kogan, who was here last week, 2 weeks ago. Dr. Kogan is the medical director. Mikhail, okay.
Misha is fine.
Misha, okay. Misha is the medical director for Integrative Medicine, associate professor of medicine in the Division of Geriatric and Palliative Care, and associate director of the Geriatrics and Integrative Medicine Fellowship Program, and director of the Integrative Medicine Track Program at the George Washington University School of Medicine. He's also the founder and executive director of the AIM Health Institute, which I don't know, will tell us about. And that provides integrative medicine services to low-income and terminally ill patients, regardless of their ability to pay. So 2 weeks ago, we talked about, he has a new book out with Joanne Lehman-Smith, who was also on. But there were a lot of medical questions, very specific medical questions that people had. And we couldn't get to it. I had like 30 questions I couldn't get to. So that's why I asked Misha to come back and just let's talk about, because each of these chapters has a specific illness and aches and pains, sleep and mood, gastrointestinal disorders, skin problems. So I thought we'd go through them and ask questions about them, and also about the delivery systems. I did not know that you could, that there were cannabis suppositories. I know about oral, that you can go to, have a brownie or you can smoke it. But so there's a lot of different things. So Dr. Kogan, why don't you start and just say, overall, I know that beyond a shadow of a doubt, because I've seen it, that marijuana tablets can be used to stop epilepsy in children. And I know about the chemotherapy, but I don't know how good is the evidence for sleep? How good is the evidence for aches and pains? How good is the evidence for GI disorders? And
well, let me.
Okay.
I want to do it in 2 steps. So first step, I'm going to challenge everybody here, including you, David. Throw any condition at me, and I will tell you that for that particular condition you just throw at me, with not acute problems, I'm talking about chronic issues, there's probably an application of a sort. And if we dive deep, I can explain why that is the case. Now, it may not be curative, it may be just a supportive, but in reality, any condition out there that is affecting our functional status and it's affecting anything chronic, any chronic condition, there's probably going to be application. So that's one. In terms of evidence, I think what I can do is the following. I can tell you where evidence is what we define as conclusive and significant. What that means in the evidence-based terms is that would be a grade A recommendation, meaning that if this would be a medication, it would be a gold standard. So gold standard medicine means it's a first line treatment for a given problem. So for insomnia, chronic insomnia, there is no prescription medications that are considered gold standard. There's not a single medication that can be used that is FDA approved for insomnia beyond 6 months. They don't exist. Not a single one. The only medications that are approved, they're approved for short-term use, for periodic insomnia, or for jet lag kind of insomnias. So the only actual golden standard for insomnia is cognitive behavioral therapy. It's behavioral intervention.
Can I interrupt? Because so you're talking about drugs like Ambien?
Yeah, they're not FDA approved. So they're not FDA approved beyond 6 months use. None of them. You can double check me if you're interested.
But benzodiazepines.
They're not approved. Not a single drug. There's not a single drug approved for chronic insomnia.
But benzodiazepines are approved for anxiety.
No. Right. They're approved for anxiety and they're used off-label for sleep all the time.
Right.
But they increase mortality. They have tons of side effects. They're pretty addictive. So cannabis until around 2 years ago
Yeah.
did not have a conclusive evidence. So it was not something that were to be used first line. And then in the last, I would say 48, 24, 36 months, we had a massive shift in data. We had several studies from states that have been tracking outcomes of use of cannabis for a long time that were pretty surprising. And very similar to what we have found with opioids, states that approve cannabis seeing about 30 to 50% decrease in total amount of opioid use in opioid-related mortality, up to 50% decrease. We're seeing exactly the same thing with all the sleep aids, whether the prescription sleep aids or the over-the-counter, so things like Benadryl, for example. So all of the use goes down, and it goes down up to 80%. So I just want listeners to get a sort of grasp of the value. In opioids, it's about 4 million daily use of prescription opioids. So 4 million drugs per day in America less since the cannabis has been approved in different states. So that translates to 4 times 300. That's literally a billion doses taken by Americans. And that translates to about 30,000 lives saved per year. Now, you're not going to hear politicians talk about it. I'm just telling you that up front, but it's a pretty significant numbers. And with benzodiazepines, it's about the same. Now, benzos are not as deadly, so I think the mortality is a lot less. So what we don't have yet for sleep is the concrete double-blind randomized data. And the reason we don't have that is quite obvious, because nobody's going to sponsor a trial like this. Again, I'm going to go back to what Donald Abrams likes to say. I don't need an evidence that aspirin works for pain. And there is no evidence that aspirin works for pain. There's never been a trial done on aspirin for pain. And it will never be, because what's the point? So it's kind of the same, actually, interestingly, with cannabis and sleep. What will happen is the dosing titration. So we will have some trials that are going to be pretty small when we will say, well, which particular products should we be using for sleep? Should we have people take gummies of 10 milligram THC capsules or sublingual oils? And what is the best? And what should be the process of titration? We don't have that data. So this is kind of still up for, providers who knowledgeable dispensary staff or the patients themselves. But definitely insomnia is I would say in my book, and literally, I'm saying literally and transfiguratively, that's in the book itself, and we talk about the sleep a lot. Definitely first line, no question. I have stopped recommending any other treatments nowadays, and that's actually a cost and logistic issue. If I send my patient for cognitive behavioral therapy, it's going to cost about $200 per treatment. Very few providers accept insurance. In DC area, I don't even know any who accept insurance for specific cognitive behavioral therapy for sleep. And the doctors who see patients for sleep, they usually give very brief version of cognitive behavioral therapy. It's not enough. You need to do 10 sessions weekly. It's pretty intense work. So it's logistics. Cannabis for sleep is going to cost $30, $50 a month. It's very easy to do. You can, it's not something that's going to have a lot of toxicity or side effects. $30 to $50 a month often equals to about the same copay that the medications do. The difference is that medications, unfortunately, disrupt the architecture of the sleep, all of them. That's why they've never been approved by FDA for chronic treatments. They're just poor choice. They knock you out, but you don't get the same rest as you would with natural sleep, not even close. And anybody will attest to that.
Well, it's kind of like alcohol. You wake up at
pretty much.
Yeah,
exactly. It's exactly like alcohol.
Yeah.
You get kind of knocked out, and then the effect wears out. And even if you take a higher dose, you're still not going to wake up the same refreshed. And like if you ever track your sleep, you touched up on sleep, so I'm going to go on a long tangent here. So I wear this Oura ring, which is a device right here, which is a device that monitors my sleep every night. So I know if I have a extra glass of wine, I'll pay for this, because my recovery score in the morning will be way lower. With cannabis, there's no such thing. I mean, it appears that there is no decrease in the quality of sleep. There's no shift. If you sleep enough, that is, of course.
Well,
But
obviously people shouldn't smoke cannabis to fall asleep because the risk of causing a fire.
well, yeah, no, but you know my opinion. I think nobody should be smoking. It has nothing to do with a fire. I mean, you can, if you don't have to smoke, you can. Yeah. So Ellen, I met with Daddy for a few hours 2 weeks ago. So I not just quite well know him. I know him personally really well. We had a dinner together. The guy can talk. His English is pretty good, so my Hebrew is rusty. So I had a very long talk with him, and he's actually not concentrating on sleep right now. He's much more concentrated on cancer. That's his main interest. And in Israel have several long-term strategies of using cannabinoids for cancer, but I don't think I can talk more about it because this is all kind of still, Daddy hasn't published this, so I'm giving heads up on things that are probably a bit anyway. So, but yeah, he's a great guy. I listened to several of his lectures. If anybody ever listened to his lectures, highly recommend. Unfortunately, so we need a lot more daddies. We need people in America to do something like this. You know, we have a problem with this level of research very in between in America, because, you know, in Israel, the whole national system authorizes this research. And interestingly, they don't actually have a lot of funding from it, from Israeli government sources. Their funding comes actually in a big way from America, from the industry itself.
I just want to sum up for what we discussed 2 weeks ago, that it's very hard to do studies of marijuana and cannabis in the United States because it's a Schedule I drug, according to the federal government, which means cocaine is a Schedule II drug. So the federal government views cannabis as more dangerous than cocaine.
Yep. Oh, yeah. Yes, which doesn't make any sense. Ellen, thanks for the link, but I already know this person really well. We've done the studies together. We actually publish stuff together. You can look it up. Okay, so let's go to pain, because the actual evidence for pain is a lot more robust compared to sleep. And that's the number one category for which in 2017, National Academies of Sciences published the conclusive data. They basically said cannabis for pain is conclusive evidence. And that would again translate to category or grade A recommendation. Again, there is not a single pill for pain that is grade A. Tylenol and NSAIDs, non-steroidal anti-inflammatories, are grade B or B minus. And then opioids are grade C. So they're really not recommended as even second line. They only recommended as a third or fourth line. And NAS said that should be first line. Again, that was 5 years ago. Nothing changed politically since. I'm just pointing that out for everybody. Not playing devil's advocate. I'm just saying that that's what it is. So that's pain. Nausea, vomiting was another grade A recommendation according to NAS, and that's probably, in terms of overall acceptance, has the highest acceptance, especially with domain of oncology, where severe nausea and vomiting related to either chemotherapy or to just the cancer itself is known to be well treated. And we have a pretty significant increase in oncologists who are actually beginning to recommend cannabis, or at least they're not opposing. Like, 10 years ago when I was starting to do this, we still had a lot of oncologists completely opposing this. And it's kind of hard to find opposing oncologists at this point.
So in terms of cancer, I know that patients get very extreme. They get methadone, they get sometimes heroin.
That's right.
Nobody seems to have a problem with that. And
well, look at the history of narcotics in this country. I mean, it was all pushed without any significant evidence. Narcotics were pushed by one rich family onto this country, and they made tremendous amount of money, the Sacklers family, even when the evidence was not existing. So, we know that unfortunately
they weren't pushing heroin though.
No, they were pushing oxycodone, which is.
So I guess my question is that, if you tell someone I have a son who's a heroin addict, they're very, very upset. But heroin and methadone are very accepted, pain medications in cancer.
Well, not heroin, right? So heroin doesn't have any medical application. You can't just buy it in a tablet form. It has to be methadone or oxycodone.
Yeah.
So
methadone is accepted as a pain.
Well, it's not just accepted. Methadone is definitely it's an effective pain treatment for certain types of pain and in certain situations. I mean, I'm a palliative care doc. Trust me, I'm the one prescribing those frequently.
Is cannabis better?
So that's a great question. What is better, narcotics or opioids or the cannabis? And I'll tell you, it actually depends not only on type of pain that you're using it for, but it really depends on individual. There are some people who just don't respond well to cannabis. It just doesn't, for whatever reason. The number I like to quote is based on observational data that when we start, say, 1,000 people on cannabis, we know that only about half will stay on that. But that half is going to be raving about the effects of it. They're going to say this is very effective. And the other half that didn't continue, believe it or not, most of these patients don't continue not because it didn't work. They don't continue because they have logistical problems. Someone at home says, what the hell are you doing? Or it's a cost, or they don't want to deal with legal problems around it, or they had side effects. They took inappropriate dosing, which happens quite a lot. They took too much as a first dose without titration when no one explained it. And now they had side effects, and it's kind of hard to break them back and say, look, let's start over. I mean, that's kind of hard to make that conviction. With opioids, the numbers are much lower. People who start opioids, it's rare that it won't work for pain. The reason it's category C, of course, has nothing to do with efficacy of opioids. It's all about the fact that the addiction potential is close to 100%, not 90% or whatever. Dependence, not just addiction. And the fact that you have to escalate the dosing and the chances of very serious side effects, we're not just talking about constipation, which could be very serious, actually, if you don't move your bowels at all. But, or breathing suppression, death. I mean, those are serious side effects, right? With cannabis, none of this happens. I think that's one of the reasons those of the physicians who work a lot with frail and older adults know that chances of side effects from any treatment is exceedingly high. So you have to first think, before you think of efficacy, am I going to harm this patient? Which is, do no harm is the first rule. It's especially applicable in older adults or in anyone who's more frail, in whom side effect profile is just higher. And so that's where the cannabis becomes gold, if not platinum, because you don't worry, you're not as worried about the side effects. Even if they do get side effects and they don't decide not to continue it, those side effects will be gone and they will be mild, and they definitely will not cause death or severe complications of any kind. And that's, I can't understate that enough. This country, for whatever reason, and actually a lot of countries, seemingly forgotten this rule of do no harm first. We use a lot of treatments on our patients that have profound risk of serious toxicities. And that has to do with the business of medicine, not with what works and what doesn't, which is, it is what it is. So pain, yeah.
Just a question. For those listening in, if you have questions, please put them in the Q&A box. Don't put them in the chat box, because that's for Joe and I in case there's a technical problem. So please put them in the Q&A box and I will read them. And I will also read some questions that people submitted in advance.
So, yep, I see the question there for Yasmin. Topical cannabinoids for TN, trigeminal neuralgia, is such an effective treatment that it's usually now my first to go. Why? Because I have never found any medications for trigeminal neuralgia come even close to efficacy of cannabis, not even close. The best medications for trigeminal neuralgia is usually either what's called gabapentinoids, medication like gabapentin or Lyrica, or TCAs or tricyclics. They have high amount of side effects and they just don't work really well. I always start with topical. The book actually outlines the dosing and which exact topicals to get pretty well. And the trigeminal neuralgia I treat similarly to peripheral neuropathy. So you start with topical. If that doesn't work, then you move to systemic. It's a good question.
What is trigeminal neuralgia?
Yeah, it's a facial pain where the nerve itself, which comes into the face, gets triggered. It can also be triggered by the way the lower jaw positioned. So it's a neurological problem. It's sometimes really hard to treat. Other treatments for it that are really interestingly effective are craniosacral therapy and acupuncture, but it's kind of outside of the scope of today, I think.
So this is TMJ, right?
Well, so TMJ is as a mandibular joint, temporomandibular joint. That's an actual physical location where the pain originates because the joint can get distracted. And trigeminal neuralgia is sort of associated with it, but it's not exactly the same. It's often the parts of the facial nerve either get compressed for whatever reason, but it may not actually have to do anything with TMJ. So people can have severe trigeminal neuralgia without TMJ.
So I have a question. So people who have a history of depression and anxiety, they have said to me they're very concerned about marijuana because they think it might have a negative effect on them.
Yeah, so they're totally misguided, right? So depression, anxiety can be cured with cannabis. It's very effective for both conditions, especially anxiety. I would say, well, anxiety can have so many different positive treatments out there, so many effective treatments. I don't necessarily think of cannabis as a first line. CBD for anxiety has a rapidly increasing amount of data. I would say that data is still not very strong, but I think it's rapidly growing. But if you talk to patients out there, they often would say that it's best ever. So anecdotal data for depression and anxiety is basically people often prefer it over all other medications when they start using it.
And how are they taking CBD?
So a CBD, you can take hemp-based CBD. Your doses should be reasonably high. Usually it's somewhere between 30 to 50 milligrams twice a day sublingual. Remember, I talked a little bit about the fact you should not be taking CBD capsules because the efficacy drops at least twofold compared to sublingual. So it's a lot better to try to put it in the mouth directly rather than swallowing the capsules or edibles. The gummies, CBD gummies are kind of scam by the most of it, because in order for that to work, your gummy has to have so much CBD. I don't really see that many of them out there. Capsules could be better, or gel caps, as we sometimes say. Could be either powder or usually there's a oil inside the capsule. So there's gel cap. So those could be a lot better because they hold oil. But the problems with gummies, you can't put as much. So they're often 5 to 10 milligrams. You have to swallow multiple gummies. It doesn't make a lot of sense. You're spending extra money on something that doesn't make sense to do. Interestingly, THC can actually cause anxiety, right? It's a common side effect. Yeah. So you have to be careful, especially if you like to smoke or inhale in any way. You actually can have anxiety and paranoia if you take too much. So it's interesting that at the low dose, THC can be potent anxiolytic, the potent anxiety medication, much more potent than CBD, milligram per milligram. But if you overdo it, then you have an opposite effect. So this is actually the theme with cannabis generally, especially with THC. The lower dose that is effective is the always right dose. The moment you keep increasing, or the time you keep increasing the dosing, you will eventually overshoot the efficacy and you can have actual exacerbation of what you're trying to treat. The great example is the nausea, right? So we use cannabis for chronic nausea. It's very effective, regardless of the cause of nausea. Of course, we just talked about cancer-related and chemotherapy-related nausea. But those people who do a lot of THC recreationally develop sometimes this very mysterious, very fascinating condition. For those of you who are interested in pathology and pathophysiology, it's called cyclical vomiting syndrome or hyperemesis syndrome. No one actually knows exactly why that happens. Ethan Rusa, that's his particular interest right now. He was just giving us a lecture at the CanX where I was about the fact that we need a lot more data, because this is, in Ethan's words, I think I can say that. He basically says the only real side effect cannabis has, in the sense that that's a serious side effect, because people sometimes have it severe. They can vomit for hours. They can get dehydrated. They can even die if they, if it's really severe. Now, disclaimer for full, I never seen this, but that's because of the type of, I'm biased, right? So I see patients that I see who come to see me. So I would never put people on the crazy doses of THC. I would always balance it with CBD and you titrate slowly. So it's just a matter of my practice. But I bet that psychiatrists or emergency room doctors by now all have seen it, because if somebody's using it recreationally, it appears to be a very, very serious problem.
In college, I had several friends who smoked a lot of marijuana and ended up with their first anxiety attack going to the emergency.
Yeah, exactly.
So we have a question.
Mm-hmm.
I think it'll be helpful. Can you define CBD, cannabinoids, and THC? Just so people know.
All right. Well, so Elizabeth, first of all, please get the book, because everything is discussed so much clearer there. There's a whole chapter called Cannabinoids Clarified. I think all of this information is clearly stated there. So I think defining these things will take a little time, but what I will do is this. So cannabinoids, or exogenous cannabinoids to be precise, is a term that describes active ingredients in the plant cannabis. I'm just going to use word cannabis. I'm not going to say cannabis sativa or whatever. I'm just going to use one word cannabis, so that's it's simplified. It's actually incorrect. There is no cannabis. It's all cannabis sativa, but we're not going to go there, because I don't want to get us wrapped up in the botanical conversation here. So the most active ingredients in plant cannabis in biomass typically are THC and CBD. THC is tetrahydrocannabinol. Actually, to be exact, it's a delta-9 tetrahydrocannabinol, and then CBD is a cannabidiol. Now, those two molecules are activated forms of the precursor acids, CBDA, cannabidiolic acid, and THC, tetrahydrocannabinolic acid. So those are the original molecules in plant, but when we hit the plant, they get converted to those two molecules. They're most prevalent by weight. THC is what everybody is after for recreational use. It's the main psychotoxic molecule in the plant. Notice the word that I just used. We don't say psychoactive anymore, because every cannabinoid is psychoactive, except for even terpenes have some psychoactivity. So if you take CBD in high doses, you will have some shift in the perception. It may be very minor. It's not necessarily high, but it's definitely a shift. So anybody who've ever taken any substantial doses of any cannabinoid will say, I feel something different on the brain level, on a cognitive level. But THC is the only one that has a potential for psychotoxicity, meaning can cause paranoia, it can cause high, it can cause low, it can cause whatever it can cause, right? So those things are depending on the dose of personal individual response, etc. So, and then of course, both molecules have very different action. So CBD is thought to be more neuroprotective, more anxiolytic, more balancing side effects of THC, etc. And then THC itself has lots of other effects, including analgesia, anti-nausea impact, and many others. So including, for example, both CBD and THC have a pretty strong anti-proliferative potential, so anti-cancer potential. But, so cannabinoid is defined as an active molecule in plant cannabis. Terpenes are the smell molecules. So those are the ones that give a given strain of cannabis a particular smell. Like linalool, for example, would be more like lavender smell. Myrcene, for example, would be more, well, pinene would be very easy. It's more like a pine kind of smell. And so, you're looking at the smells depending on what's most prevalent terpene. And then there's about 200 at least active molecules. So I don't think it's worth going and discussing them. But please, if you're very fascinated by this, the chapter, I think, does a pretty good job, and it's relatively easy to read. I think part of the problems that I find with a lot of academic books that are out there, they're just too detailed and unnecessarily complicated. There's enough to learn in this topic, and I think going on tangents about some minor cannabinoid may actually be distracting, not necessarily all that helpful. That's more for researchers, clinicians, and
I have some questions I'm going to read.
enthusiasts. Sure.
Okay. So the first one, do you have any comment about Dr. Roz's pain reduction claims with respect to his CBD product? Is there any?
Yeah, there is none.
Okay.
Well, so let me put it this way.
Okay.
There is a controversy there because there's more and more data coming out and saying if you take CBD and THC together, you potentially gonna block analgesic effect of THC. We know about this for other conditions. So for glaucoma, for example, people sometimes smoke THC. Now there's a process of trying to develop eye drops for THC. But we know that if you put CBD in the eye, it's actually going to increase the intraocular pressure. So CBD sometimes have an opposite effect than THC does. Now, where CBD shines is an anti-inflammatory agent. So if you have an arthritic condition that's causing pain, and then you take CBD to suppress the inflammation, I'm all for it. But taking CBD for neuropathic pain makes zero sense. And I don't care who says what out there. There is no data to support that claim.
Okay. What are your favorite routes of delivery? What conditions are best treated with cannabis suppositories?
Yep. Right. That's a great question. Actually, suppositories is probably my second most common and most preferred. And there's two reasons for that. So one, well, sublingual is probably my most preferred. Why? Well, it's the easiest one to do. It tends to be the cheapest often because people tend to, when they inhale, they waste a lot of product. You can buy, let's say, a half an ounce or whatever you can buy, and the flower is going to go a lot faster than the sublingual tincture. So the cost wise, so that's, and also it's very precise. Like when you're smoking or vaping, unless you're using very advanced system like PAX or Volcano, it's hard to actually get dosing half precise. You have to struggle to figure out how you do this. And burning flower or vaping flower in simpler devices is even less obvious. So it's going to be a lot less precise. So if you, that's more precise to do sublingual. The benefit of rectal is that you can, if you have a localized symptom in anything pelvic related or a back pain, it seems to be quite often the number one preferred delivery. And by the nature of what I do, I work a lot with the older adults and with people with a lot of serious chronic conditions. That's the area that's often affected one way or another. And so I found that, and you can take a pretty exuberant doses, 50 milligrams of THC, and not get any psychotoxic effect. Mm-hmm. Now, of course, the critics of suppository saying, well, that means it doesn't work. I will tell you, whatever they say, I don't care. For localized conditions in the pelvic area and in the back, it's the godsend for a lot of patients because they can take a high dose, have their symptoms very well managed, and not have the psychotoxic effect. Anything you take systemically otherwise, inhaled, sublingual, it's relatively easy to overdose. You take a bit more and now you're high. It just doesn't really happen that way with suppositories. So I find it quite fascinating. For that reason, it's probably my preferred because you can do that way. The problem with suppositories is the cost. But I teach some of my patients, those who want to do it, how to make suppositories from the oil you can buy from dispenser. But suppositories are also getting more and more available. They're just pricey. So those are my two favorite. And then, of course, the third one is topical. So I absolutely love topical. I use topical in my family all the time for everything. Bruises, cuts, herpes on the lips, eczemas, cannabis now first line. Why? Simple use, cost, safety. I hate topical steroids. They thin the skin. They cause long-term side effects. So I try not to use them unless there's, and another, you have some other cheap over-the-counter topical Benadryls and other things, but they all have very limited applications for, yeah.
And
No, but so topical means a lot of things. Salve is just one type of topical. You can have creams. You can actually just have direct oils right on the skin. So you can take sublingual oil and apply it on the skin. It's more concentrated that way. You can have chopsticks, so just regular lipstick balm. You can have nowadays there are patches. Patches can be extremely effective for certain things. They're very pricey, so I don't use them a lot because they're so expensive. But a lot of patients say that for back pain, for certain types of back pain that's more superficial, patches can be very, very effective. And again, the benefits of doing topicals similar to suppositories, we rarely, if ever, see any central toxicity and any getting high.
Okay, so can medical marijuana be helpful following surgery, hip or joint replacement as a substitute for narcotic painkillers?
Yes, all the time. Yeah.
Okay.
And it's interesting that we used to think that after surgery, cannabis has no role to play. Turns out that's wrong. Turns out that there are patients who can use, I have patients now more increasingly use the cannabis right after surgical procedures instead of opioids. And for some courageous patients, it works even better than opioids. I find it pretty fascinating. What convinced me to try this is a pretty old study by Donald Abrams, where he took acute pain model, and he basically had people, he put the nauseous, painful stimuli on the skin, and then he had people smoke a cigarette with the cannabis or not, and then in a controlled setting, he showed that acute pain can be controlled with cannabis. This was the first thing for me to try, but there's been quite old idea that cannabis doesn't work for acute pain. I think that's getting challenged, and I'm guessing that in the next 5 to 10 years, we're going to find particularly we're going to have clarity for which types of acute pain we should be using cannabis. I'm not 100% clear with that.
So I have a question. So
Uh-huh.
as you said, it's very difficult or basically impossible to do controlled trials in the United States.
That's going to change. It's already changing. We're seeing an increase in trials. We're seeing more options at NIDA. NIDA is a national, it's a drug administration that controls the supply for research. And historically, the biggest problem with the research was that they had so few choices that whatever the research you do is completely irrelevant because people get totally different things in dispensaries. So that's changing rapidly, well, nothing is rapid and it's changing slower than I want, but it's changing. So we're probably going to see more choices and better research.
Okay, but what about the countries like Switzerland, the Netherlands?
So they,
Israel,
yeah, still the most of the hardcore applicable research comes from Israel. The problem is Israel researchers, what they grow. So whatever their population in Israel have access to, that's what they research. And I think what will end up happening is that we're beginning to see industry doing their own internal research in a rapidly increasing form. I think that's fine for now. I think it's okay. I think there's going to be a lot of abuse, of course. That's just going to happen. And eventually it'll get regulated. But what really has to happen is that NIDA stops controlling the research stocks. They need to open it up and say anybody can do research with anything you grow, with anything you make, as long as you follow certain guidelines, certain types of regulatory mechanism. There has to be a strong regulation on making this product safe and clean, because the big problem is also, of course, contaminants.
Here's a question. How old are the youngest patients for whom cannabis should be recommended?
From the birth,
okay.
Pretty much. I mean, it all depends what particular products you're using. You guys go watch Sanjay Gupta Weed, the most recent December, I think it's number 6, if I'm not mistaken, about the efficacy of cannabis for autism. So small kids. Yeah, there's no age, yeah, upper or lower limit. We have this from birth. In fact, we have the system endogenously before birth. Every child, every fetus, every baby makes their own cannabis. And actually, the peak production of our own internal cannabis, anandamide, 2-AG, and others, is age about 10 to 12. And after that, game's over. Just kidding. But after that, there is a decline. So this is the only system that I'm aware in our body that seems to decline before puberty, which is, or right after puberty, but you're not fully yet matured, right? So you're not, the opioid system begins to drop after 25 something, and hormones peak even later. So why that is, I don't know. It's a fascinating research. At some point, I should probably try to answer that.
So is this the cannabis system you're talking about?
Yeah, and the cannabinoid system, right? So we make our own cannabis all the time. I'm sure that's, I think we talked about this last 2 weeks ago, and we covered this in the book very thoroughly too. So our endogenous system is probably one of the most profound regulatory systems we have. Remember when I said challenge me and to throw a condition at me, and I will tell you there's a role for cannabis? And that's why, because our system is entirely regulated by endocannabinoid system. The only place that has nothing to do with endocannabinoid regulation. Let's say a bonus. If anybody answers this, they get my book for free. I'll mail it to you. If you can answer this question, what is the only organ or only tissue in our system that has no effect of cannabis at all? You actually, if you followed my talks, you may be able to answer that. So I'll give people 5 minutes. How about that?
If you know the answer, put it in
the chat. Yeah.
Yeah, put it in the chat.
And then if it's right, you'll put your address and we'll take it and we'll mail you the book. But that's probably the reason why there's no age. Now, you don't ask me questions about kids practically, because that's not my population. I've recommended it very few times, but I know people who do, and I would refer Patricia Fry in our area is kind of the outmost expert on this topic for pediatric population. I sometimes send patients to her.
So as you know, there's a big pain is a big industry.
Yeah, huge.
So here's a question.
Mm-hmm.
Are cannabis companies shares a good investment in today's market?
I think the industry as a whole is a good investment because it's probably here to stay forever. It'll mature. But, any immature industry risk is very high, right? So which one's going to become Tesla and which one's going to stay some debunked small brand? I don't know. I can't say to speak to that. But, there are some index funds, cannabis index funds you can put probably money in. But talk to your advisor. I'm a doctor. I have no. There's a clinical question that I like there. It's an appetite question. What is best for increasing appetite? So Ellen, actually, shockingly, the best thing for appetite is no medical prescription. It's an exercise. Unfortunately, or acupuncture. I find sometimes acupuncture is very effective. But I really don't think that cannabis or any kind of medications out there are very good appetite stimulants. They sometimes work well, but they're very unpredictable. For each patient for whom it works, there's 5 that it's going to do zip, absolutely nothing. Maybe a year, 2 years ago, I got very fascinated by this new minor cannabinoid called cannabidiol or CBG. And I had few people who do really well with appetite on it, but I also found it's just not as predictable either. So unfortunately, I wish I could tell you it's a highly evidenced and everybody knows about munchies after eating. The problem, that doesn't translate to any chronic effect. In fact, people will have munchies and then they will not go hungry for a while. So it's not enough. You're going to have to smoke all the time. And often people don't like it because it feels you can't have appetite without it. So I definitely discourage people from using cannabis for appetite, unless you're in a very advanced cancer situation. Then it's a whole different conversation. I don't want to talk about palliative domain because there every rule changes. So in palliative domain, it's all about quality of life in the last months or weeks of living. there we tend to encourage cannabis very heavily because it's often the only tool that improves quality of life. And you have to be quite aggressive there. So the dosing there sometimes are much higher. Sometimes we mix it with other substances because there are other symptoms. This is very typical, mixed with opioids for pain if the pain is very severe and cannabis is not enough.
So we have one guess, the heart.
Nope,
No.
totally wrong.
And I'm not sure if someone guessed the nervous system.
Oh no, that's the opposite. The cannabis is very high. Well, okay. So I'll give people, I'm not going to spoil, we will get back to it if there's no precise answer. But I can give in a couple of minutes, I'll give a little hint. And the part of the hint is already in the answers, but it's not the right answer yet.
Kidney?
No.
Okay.
All right. Okay. Let's do a couple other questions before I start going back.
Okay.
So is there a universal mechanism by which cannabis works that makes yeah, exactly. That's what I was just explaining. Because we have our own endogenous system that constantly modulates all of our metabolism, that's the effect. So, that's exactly right. So no, not lungs, definitely not kidneys, definitely. So can it be used for asthma? Yes or no, and if yes, why? Okay, so yes, it can be. It's not very good tool. Why? Because you have to inhale it. For cannabis to work for asthma, you have to put it there. And if you an acute asthma situation and you smoke and you may feel a little bit better, sounds okay. But smoking or inhaling, vaping, even cold vaping or cooler vaping, anything for a lot, it's just it doesn't make a whole lot of sense. But I would say that I have seen some patients use it that way, and I don't discourage it if it works very well. Yes, but it helps to open up the airways. It's a bronchodilator. It's a mild bronchodilator. It's not as strong as some medications, but it works. All right, hint. No, not bone. Bone actually has a very significant CB2 receptor present. It is somewhat related to nervous system. I'll leave it at that, but it's not a nervous system. The nervous system has exceedingly high CB1 receptors. There is somewhat of, yes, it's part of a nervous system, but you have to be specific, very specific, because that is critical. All right. And also that is critical for the safety. That's all I'm going to say.
How about the brain?
Okay, well, no, not brain.
Okay. How long does oil last in a dark bottle in a cool space?
I think a year is a safe bet, but you have degradation occurs beginning to occur in a few months, but it's very slow. So you can have active ingredients like THC, say, safe for definitely close to a year. So yeah, it's pretty shelf stable. I think each cannabinoid has its own degradation process. The acidic forms are least stable, I think. So the CBDA and THCA. So you have to be very more aggressive with those. So you probably don't want to store them for a very long time. But the industry is also figuring out stability ways. So they putting the other molecules in there, the preservatives that stabilize the cannabinoids. I'm not a big fan of that. I much rather we don't use any preservatives and just use oils a bit more frequent. So maybe have them sit on a shelf for up to 6 months and then get a new bottle.
Okay, so I found this buried somewhere, old bottle, Centrum vitamins, and it says expired November 21.
Yeah.
So do the products, the CBD?
Well, so this is different. I mean, the tablets are often, when they press together, their stability is much better. And the day of expiration mostly has nothing to do with an actual expiration. They just want to sell products. I remember I was reading somewhere in JAMA, actually, in a very famous medical journal, somebody discovered penicillin from war, like it was 50 years old, and it was still 90% effective.
The Army uses drugs that have expired for 5 years.
Oh yeah, it's perfectly fine. Now the difference is the liquids. So the liquids tend to go bad often a lot faster. So you can't really compare the oil, which was a great question, to the Centrum. But David, why are you taking Centrum? You should not be taking crap like that. This is the worst vitamin out there. I'll be open. If you look at the label, half of the stuff in there is junk. It's fillers and colorings. You should, the vitamins have to be good, just like any other product. And Centrum is the worst.
The worst.
Oh yeah, by the head down. Well, because there's studies saying that Centrum harms people. So there's a study showing that Centrum increases mortality, that the poor quality multivitamins dramatically increase mortality by close to 10%. Why? Synthetic vitamins. Synthetic vitamins, unfortunately, have to be detoxified. So our body has to take them and convert them to safer ingredients, and that uses your own detox pathways. Get rid of the Centrum Silver. Need an advice? I'll send you good quality companies. There's thank God, a lot of them. All right. I hope I don't get killed by who's making the Centrum Silver, CVS. I hope they don't eliminate me for saying this. But I've freedom of speech, right? I have my right to say that.
Yeah, of course. Yeah. Mel Brooks is a 2,000-year-old man. They asked, "Why do you live so long?" He said,
Aliza, glial cells have a lot of cannabinoid receptors.
So I think we got to get
right. Yeah. So, well, the hint is that it's very close to brain. It's very close to brain, but it's not brain. That's pretty much giveaway, I think, already. But okay, now if somebody does get their answer right, they have to say why that particular tissue is so important that.
So we had
for not having cannabinoid receptors.
So we had the pituitary.
I'm surprised that nobody is Googling this. No, pituitary is a, I actually don't know, but pituitary is a pretty specific tissue. I don't think I can know for sure, but I'm guessing it has receptors.
Okay. Well, a lot of people guess cerebellum, thyroid, spinal cord.
Nope. Spinal cord, nope. But that's not far off. Again, people are like, close. All right. Well, maybe nobody's going to win. Whatever.
Maybe give us the first letter.
Eyes. No. So eyes. This is what I'm interested in right now. So eyes have a lot of cannabinoid receptors. Eyes are very heavily regulated. Now, they're not just having cannabinoid receptors. They have other receptors that cannabis impacts. So this whole GRP receptors and TRPV. So there's a whole series of receptors which cannabis can impact, and eyes actually have a lot. And that's why in glaucoma, THC is potentially been a drug of interest for a long time. And in fact, the little historic, the first compassionate authorization in the United States was for glaucoma, was for a patient who had a severe glaucoma, was refusing the drugs, was smoking pot heavily, saying it's the only thing that works with glaucoma. And it's not a great use, smoking for eyes. Obviously, it would be a lot better to put it in the eye, some kind of drops, but we don't have them yet because the ophthalmic preparations require a lot more because they have to be sterile. So they're a lot harder to make. And also the cannabinoids are very lipophilic. So they like to be in fat, but the eye doesn't like to have fat in it. It wants some kind of saline or aqueous water solution, and cannabinoids don't dissolve there quite easily. That's changing. There's new preparations. I'm pretty sure that in the next 5 years, we're going to have an eye cannabis preparation.
So where do you find someone like you?
Yeah.
I mean, we all go to internists who,
Yeah, that's probably one of the most important questions for today. So there are a few places you can. So if you're in a state where you have medical cannabis approved, the states would have a list of trained providers. Every state does. Now, it may be a little convoluted to find because often they're not necessarily, the government websites are not the easiest one to navigate. There are a couple of large organizations. So Society of Cannabis Clinicians, which is a nonprofit, they have a lot of people who they're members. So pretty much anybody there would probably be totally fine. Leafly is a good resource. Now, Leafly doesn't necessarily show all the cannabis practitioners. I don't think I'm even listed because I don't want to pay them money for that. But it's so that's actually probably a right answer, but the hair is not a living tissue. So, okay, I guess if nobody answers, I'll have to send the book to Bill. That's probably right. I just never realized that. I'm thinking of something else, but Bill, I think we're going to have to get you a book because I'm pretty sure, I'll have to look it up, but I'm pretty sure that hair is considered a dead tissue, right? So it probably does not have receptors, probably same with nails, I would think, but all right, I'll say now that somebody's getting the book. So it's actually brainstem. And the brainstem is also the area where the opioid receptors are exceedingly high. And that's why there hasn't been a single death from cannabis in the entire human race existence, right? So you have thousands, if not millions of deaths from opioids every year. That's because the brainstem concentration is for the opioids is high, and there's almost no CB receptors, no cannabis receptors. Why that is, that's how we made. So you can suppress the respiratory drive with cannabis because the place where respiratory rate is regulated, brainstem is not impacted. So that's the importance. But I'm sure hair and nails are correct too. I have a feeling so. And there may be some other tissues that have lower amount of cannabinoids, but it's either CB1 or the CB2 receptors, and they're pretty ubiquitous, like especially in places like, for example, immune system. Especially CB2 receptors in the immune system are highly prevalent. In fact, it's thought to be one of the most important regulatory system of our immune system, the cannabinoids.
So we're going to end in a few minutes. Where can people get your book?
Amazon is fine. Any of your favorite bookstore, Barnes and Noble's, pretty much any book. I am personally a huge fan of Audibles, just because I'm a dyslexic and reading for me has never been easy. So Audible. Now, little bonus there. Joan and I have recorded a pretty fun, which I think is fun. The intro, it's a pretty long, like we just chatted there. I think it's really fun. So you get a little bonus that you can't get if you read the book. But Kindle, any of your Amazon devices related. And I think it's even there are other formats. It's a Penguin branch. It's Avery is a part of the Penguin Random House. So they've put book everywhere pretty much. So yeah. And again, it's titled Medical Marijuana, Dr. Kogan's Evidence-Based Guide to the Health Benefits of Cannabis and CBD. I think pretty much almost everything we discussed today is in the book. I think, as I said earlier, one of the strengths of the book is how easy it's written and yet comprehensive and very precise for the specific conditions. So if you have a particular question about a given problem, now, of course, I'm not telling you that this is a substitute for medical care, but you can take that information and go to your medical provider and literally give them the book or her or give the information and say, hey, what about this? And that's a starting point. But ultimately, of course, if you get interested in this topic, you should be getting a provider who's knowledgeable. And yes, it's not, as we spoke just before, it's not necessarily easy, especially if you live in a state where it's not available. I'm not a huge fan of, there's a lot of cannabis doctors out there and a lot of coaches who would work with you even if you're in a different state. The problem is that it's a little tricky. You need to know local logistics. So I never take patients from other states unless I work with their local doctor. Now, if I work with their local doctor, which I've done before, and I would be more like, if anybody wants to do it, I'm all game. I worked with all the states as long as the local physician or a provider would be willing to work with me, because we would need to figure out how to practically get the process going, how to get the medical cannabis card. But then I can look at the dispensaries and say, okay, go get this. Yeah.
Okay, so I want to thank you, Misha, again for spending time with us. And
Thank you.
Bill will email his address.
Yeah, Bill, don't forget, send us the address. You'll get a copy. You'll get the autographed book.
Yes.
And thanks for thinking so outside of box. You outthought me. I love that.
Oh, okay.
I will look it up now. Right after we're done, I'll have to look up if there is actual receptors in the hair. I don't know.
All right, great talking to you as always. Everyone, please stay safe out there. And we're going to be doing long COVID. I'm still zeroing in on a date, but that's going to be our next topic. So anyway, everyone take care and we will see you soon and please stay safe out there.
Stay safe, everybody. Thank you so much, David, for
Okay.
having me.
A
And
pleasure.
Joe.
Good night.